Hi everybody, we continue to talk about sarcoidosis. I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and you are on Dr. Y. So once again, what is sarcoidosis? Sarcoidosis is an inflammatory disorder resulting in non-caseating granulomas in one or more organs and tissues. Etiology is unknown. The lungs and lymphatic system are most often affected, but sarcoidosis may affect any organ. Pulmonary symptoms range from none to cough, exertional dyspnea, and rarely lung or other organ failure. Diagnosis usually is first suspected because of pulmonary involvement and is confirmed by chest X-ray, biopsy, and exclusion of other causes of granulomatous inflammation. First-time treatment is corticosteroids. Prognosis is excellent for limited disease but poor for more advanced disease. So concerning prognosis, although spontaneous remission is common, disease manifestations and severity are highly variable, and many patients require corticosteroids to relieve symptoms or progressive organ function decline at some time during the disease course. Thus, serial monitoring for evidence of relapse is imperative. Almost two-thirds of patients with sarcoidosis eventually achieve remission with few or no sequelae. In about half, 50% of patients who have spontaneous remission, so remission occurs within the first 3 years after diagnosis. Fewer than 10% of these patients relapse after 2 years. Patients who do not experience remission within 2 to 3 years are likely to have chronic disease. Sarcoidosis is thought to be chronic in up to 30% of patients, and 10 to 20% experience permanent sequelae. The disease is fatal in 1 to 5% of patients, typically due to respiratory failure caused by pulmonary fibrosis, and less often due to pulmonary hemorrhage caused by aspergilloma. However, in Japan, infiltrative cardiomyopathy causing arrhythmias and heart failure is the most common cause of death. Prognosis is worse for patients with extrapulmonary sarcoidosis and for blacks. Remission occurs in 89% of whites, 89% of whites, and 76% of blacks with no extrathoracic disease, and in 70% of whites and 46% of blacks with extrathoracic disease. So good prognosis signs include Löfgren syndrome, triad of acute polyarthritis, erythema nodosum, and hilar adenopathy. Poor prognostic signs include chronic uveitis, lupus pernio, chronic hypercalcemia, neurosarcoidosis, cardiac involvement, extensive pulmonary involvement, and or development of pulmonary hypertension. Little difference is demonstrable in long-term outcome between treated and untreated patients, and relapse is common when treatment ends. So treatment of sarcoidosis. First of all, non-steroid anti-inflammatory drugs, corticosteroids, immunosuppressants, and anti-tumor necrosis factor alpha antibodies. Because sarcoidosis often spontaneously resolves, asymptomatic patients and patients with mild symptoms do not require treatment, although they should be monitored for signs of deterioration. These patients can be followed with serial chest X-rays, pulmonary function tests, including diffusing capacity and markers of extrathoracic involvements. For example, routine renal and liver function testing, annual slit lamp ophthalmologic examination. The frequency of follow-up testing is determined by the severity of the disease. Patients who require treatment regardless of stage include those with the following: worsening symptoms, limitation of activity, markedly abnormal or deteriorating lung function, worrisome X-ray changes, cavitation, fibrosis, conglomerate masses, signs of pulmonary hypertension, heart, nervous or eye involvement, renal or hepatic failure, moderate to severe hypercalcemia, dysforging skin, so lupus pernio or joint disease. Non-steroidal anti-inflammatory drugs are used to treat musculoskeletal discomfort. So corticosteroid management begins with corticosteroids. Symptoms management. The presence of chest imaging abnormalities without significant symptoms or evidence of decline in organ function is an indication for treatment. Standard protocol is prednisone, 20 to 40 mg by mouse once a day, depending on symptoms and severity of findings. Alternate day regimens may be used. For example, prednisone 40 mg by mouse once every other day. Although patients rarely require more than 40 mg daily, higher doses may be needed to reduce some complications in neurologic disease. Response usually occurs within 6 to 12 weeks, so symptoms and pulmonary function test results may be reassessed between 6 and 12 weeks. Chronic insidious cases may respond more slowly. Corticosteroids are tapered to a maintenance dose, for example, prednisone 10 to 15 mg day, after evidence of response, and are continued for an additional 6 to 9 months if improvement occurs. The optimal duration of treatment is unknown. A premature taper can result in relapse. The drug is slowly stopped if response is absent or equivocal. Corticosteroids can ultimately be stopped in most patients, but because relapse occurs up to 50% of the time, monitoring should be repeated, usually every 3 to 6 months. Corticosteroid treatment should be resumed for recurrence of symptoms and signs. Because angiotensin converting enzyme ACE production is suppressed with lower doses of corticosteroids, serial serum ACE levels may be useful in assessing adherence with corticosteroid treatment in patients who have elevated ACE levels. I think it's very interesting information concerning inhibition of ACE production by corticosteroids. Inhaled corticosteroids can relieve cough in patients with endobronchial involvement or with hyperactive airways. Topical corticosteroids may be useful in dermatologic, nasal sinus, and ocular disease. Prophylaxis against pneumonia, pneumocystis jirovecii pneumonia should be considered while patients are taking more than 20 mg prednisone daily or its equivalent for more than a month, and for those who are taking immunosuppressants. Alendronate or another bisphosphonate may be treatment of choice and prevention of corticosteroid-induced osteoporosis. Using supplement calcium or vitamin D risks hypercalcemia due to endogenous production of active vitamin D 1,25 dihydroxyvitamin D by sarcoidal granulomas. Serum and 24-hour urinary calcium measurements should be normal before starting such supplements. The presence of chest imaging abnormalities without significant symptoms or evidence of decline in organ function is not an indication for treatment with corticosteroids. Immunosuppressants are often effective in refractory cases. For example, immunosuppressive drugs have been used when patient cannot tolerate prednisone. Sarcoidosis is refractory to moderate to high dose of prednisone. Prednisone dose cannot be tapped below 10 to 20 mg daily after 3 months. So prednisone dose cannot be tapered from below 10 to 15 mg daily after 3 months. Prior to adding other immunosuppressants, possible reasons for lack of clinical involvement, such as non-compliance, comorbid disease, pulmonary hypertension, and end-stage fibrosis should be considered. Methotrexate is the most commonly used immunosuppressant. Patients should be given a 6-month trial of methotrexate 10 to 50 mg week. Patients should be tested for infection with hepatitis B virus and hepatitis C virus before methotrexate is started. Initially, methotrexate and corticosteroids are both given over 6 to 8 weeks. The corticosteroid dose can be tapered and in many cases are stopped. So the maximum response to methotrexate, however, may take 6 to 12 months. In such cases, prednisone must be tapered more slowly. Serial blood counts and liver enzyme tests should be done every 1 to 2 weeks initially, and then every 4 to 6 weeks once a stable dose is achieved. Folate 1 mg by mouth once a day is recommended for patients treated with methotrexate. Other immunosuppressants include azathioprine, mycophenolate, cyclophospholamide, levodopa, and hydroxychloroquine. For hydroxychloroquine 400 mg by mouth once a day or 200 mg by mouth twice a day can be effective for treating hypercalcemia, arthralgia, skin sarcoidosis, or enlarged, uncomfortable, or disfiguring peripheral lymph nodes. Ophthalmologic evaluation should be done before hydroxychloroquine is started and every 6 to 12 months during treatment to monitor for its ocular toxicity. Hydroxychloroquine. Hydroxychloroquine. Okay. So hydroxychloroquine. So relapse is common after stopping as an immunosuppressant. Relapse is common after stopping an immunosuppressants. So anti-necrosis factor alpha antibodies, infliximab, can be effective for treatment for chronic corticosteroid-dependent pulmonary sarcoidosis, refractory lupus pernio, and neurosarcoidosis. Patients should have a purified protein derivative (PPD) or interferon gamma release assay for tuberculosis before beginning therapy. Infliximab is given intravenously 3 to 5 mg/kg once, against 2 weeks later, then once per month. It may take 3 to 6 months for maximal response. Adalimumab can be considered for patients who have been tested successfully with infliximab but have developed antibodies or infusion reactions. Patients who have a heart block or ventricular arrhythmias due to cardiac involvement should be an implantable cardiac defibrillator and pacemaker placed, as well as drug therapy. Non-available drugs have consistently prevent pulmonary fibrosis. Treatment of sarcoidosis associated pulmonary arterial hypertension is supportive with diuresis and supplementary oxygen. So far, therapy with pulmonary vasodilators haven't been found to be beneficial. Organ transplantation is an option for patients with an end-stage pulmonary, cardiac, or liver involvement, although disease may recur in the transplant organ. Moderate or severe impairment of pulmonary function may predict mortality in patients with sarcoidosis who are infected with viruses, as in patients any viruses. So key points. Systemic and extrapulmonary involvement are common with sarcoidosis, but more than 90% of adult patients have pulmonary involvement. Obtain a chest imaging study, but confirm the diagnosis by biopsy, usually endobronchial ultrasound-guided transbronchial needle aspiration of a mediastinal or hilar lymph node. Assess pulmonary severity with pulmonary function testing and exercise pulse oximetry. Tests for extrapulmonary involvement with ECG, slit lamp examinations. Renal and lymphatic function tests and serum and urinary calcium testing. Treat patients with systemic corticosteroids when indicated, for example, severe symptoms, hypercalcemia, progressive decline in organ function, cardiac and neurologic involvement. Treat with immunosuppressants if patients cannot tolerate moderate dose of corticosteroids. Sarcoidosis is resistant to corticosteroids, or if corticosteroids are required long term. So that's all. That's all concerning concerning sarcoidosis. Thanks you for your attention. Don't forget to follow and subscribe our channel, Dr. Y, and I do appreciate if you can continue to give your donations. How to make your donations you can find in the description of this video. Goodbye and God bless you.